Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for Cancer Care Ontario's Synoptic Pathology project, and also on behalf of the Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I'd like to welcome everyone to today's education session on the new CAP checklist for ovarian cancer with our guest speaker, Dr. McLachlin. Before I introduce Meg and we get underway formally, I'd like to take care of a few housekeeping items. Today's presentation will be approximately 20 minutes in length and will include about 60 minutes of presentation time followed by 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email links once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon the completion and submission of evaluation forms available electronically. Information for accessing the evaluation form was provided in the notice for the session previously distributed. Please note that CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The recorded sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Please note that everyone's line will be automatically muted for today's presentation, and we request that you hold all of your questions until the question and answer portion of today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of the teleconference, please call the WebEx support line at 1-866-229-3239. During the question and answer portion of today's presentation, I would ask that you use the chat section of the WebEx to pose your question. For instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. We encourage you to forward your questions anytime during the presentation using the chat feature. In order to avoid question collisions, I will pose the submitted questions on your behalf as long as time permits and in the order in which they appear. In the chat window, please include the following information: your institutional name, the name of the individual posing the question, and then finally your question. It is now my great pleasure to introduce Dr. McLachlin. Dr. McLachlin is currently the Deputy Chief of Pathology at the London Health Science Centre and a professor in the Department of Pathology and OBGYN at University of Western Ontario. She is the chair of the OMA section on laboratory medicine. Nationally, she is the past chair of the Canadian Society of Cytology. Currently, she chairs the Pan-Canadian Cervical Screening Initiative for CPAC. Current interests include the development of a standardized programmatic approach to cervical cancer screening, the appropriate use of new screening technologies, and quality assurance in pathology. Meg lives in London and is busy with the care and feeding of her one husband, 2 dogs, and 2 children, and I think she has a little bit of time for drinking expensive white burgundies and also high-end Napa Chardonnays. Meg. Meg, you ready to go?
I seem to have lost Meg again. Just hang on just a second, please. My apologies for this.
Hello, can you hear me now? Hello?
Yeah, we can hear you.
Oh, yeah, okay, so let's start. That was a little frustrating. All right, well, thank you very much, John, for that introduction, especially that last bit. And thank you for asking me to give this presentation. I'd also Oh, dear. There we go. Let me just start out by saying that I have no financial relationships to disclose, and I'm not going to be discussing off-label use or investigational use during my presentation. What I would like to talk about in the next hour or so is giving an overview of the cancer stage checklist, of course, comparing and contrasting it a little bit with the fallopian tube checklist and talking about some of the areas where it's a bit of a tricky checklist to use. I do want to focus on grossing protocols because I think, like most specimens and possibly more specifically for ovary, getting the grossing right is gets you 90% of the way there.
Hey, Robert,
When we're talking about the checklist, I'm going to be focusing on a couple of areas, specifically ovarian cancer type and grading, some special circumstances that you need to think about, and also the alignment of the FIGO and TMN staging system. So with that, let's get started. This is the protocol that we're going to be speaking about. It was posted in October 2009 and pertains specifically to carcinomas of the ovary, and that includes quite a wide variety of tumors, mainly the borderline and malignant surface epithelial tumors, and in those, it's really well focused towards the serous adenocarcinomas. But this checklist can also be used with germ cell and sex-supported stromal tumors, and throughout my talk, I'm going to be highlighting some of the areas where, although it doesn't fit perfectly, it can certainly be used. Let me also point out that there is a second protocol available in the GYN section for carcinomas of the fallopian tube. And for many years, this may not have been significant to know because fallopian tube carcinomas were considered very rare. But at this point, there's been a major change in our concept of the origin of most serous epithelial tumors. Much of this concept relates back to the seminal paper published by a large Canadian group, including Pat Shaw and Terry Colgan, which were looking at prophylactic salpingo-oophorectomies from patients at a higher risk for ovarian and breast cancer because of their BRCA status. And I'll point out there a significant conclusion here is that when tumors were found, they were found in a small percentage, but very frequently these tumors were arising in the fallopian tube and very specifically in the fimbriae of the fallopian tube. And this study and several others really instituted a flurry of activity. And our concept these days is that many, if not most, ovarian tumors may actually arise in the fallopian tube. I think what the important thing to keep is considering the site of origin. And although this is a quote from the checklist paper that says that although this is an important area of academic activity, there really isn't enough evidence right now to change the way that we decide what the primary site of most serous tumors are. In fact, it still goes back to bulk of the tumor right now. This may certainly change in the next few years, but for right now, the same rules apply. When you're choosing which checklist to use, you go by where the bulk of the tumor is. So for most tumors, the bulk of the tumor arrives within the ovaries, and it's appropriate to use the ovarian checklist. Some tumors you will see, though, the bulk of the tumor, which is usually not very bulky, is within the tube, and you may find a intraepithelial component as well. Usually in these tumors, there's only very minimal surface involvement. These are the cases where it's appropriate to use the fallopian tube checklist, and although I won't be going into it in detail, it does have many similarities to the ovarian one. The third site, within the TMN classification, it states the classification and staging for ovarian also. And a peritoneal tumor is one where there's extensive peritoneal tumor with only minimal ovarian cortical or serosal involvement, and the numbers of less than 5 millimeters squared have been attached to this. There is not a checklist for peritoneal carcinomas. The ovarian one can be used, although you may have to put some comments in about site of origin, but otherwise the staging of both ovarian and peritoneal tumors are quite aligned. Again, this is academic interest. It's certainly going to have a big change the way we think about ovarian tumors, but right now, whether a serous tumor is ovarian, tubal, or peritoneal, the treatments are based on the overall stage and are very similar. So I wanted to talk about the staging of ovarian tumors because although it follows the TMN classification, it does have some differences. And you'll see here that there's both clinical and pathologic staging listed. Ideally, ovarian carcinoma should be pathologically staged with confirmation of the extent of disease. And in most cases, the important negatives, being able to show that there's a negative peritoneal biopsies, are very important for staging. Many cases now, though, we're seeing more of a clinical staging system. Patients that will have a preoperative biopsy or a fluid specimen that is called positive for serous carcinoma, those patients may have neoadjuvant chemotherapy and we may not come to surgery until after that chemotherapy is finished. In those cases, they may be more appropriate to stage them clinically, and the pathologic surgical staging needs to note that. I'd also say that the ovarian cancer staging doesn't exactly follow the TMN rules, although it would seem to within this chart, and that's because the majority of GYN oncologists and clinicians are much more likely to be familiar with the FIGO grading system. There's certainly very nice alignment between TMN and FIGO staging, but I think you'll find that most of your GYN clinicians are going to be much more familiar with FIGO. I think it also doesn't play by the rules because, as we talk about later on, you'll see that many of the things that are included in the primary tumor use words like pelvic extension, implants, and even the word metastasis. So in many other tumor sites, that sort of classification would be going into the M classification. For ovary, it almost entirely fits within the T classification, and the majority of the staging that's going on is your assessment of the primary tumor and any sort of peritoneal extent. Regional lymph node metastases are important, and distant metastases are actually quite rare in this disease. So it doesn't exactly follow the TMN rules, but there is nice alignment between FIGO and TMN that makes them easily translatable. As I said earlier, I think one of the most important things is getting the grossing right, getting the right description in, getting the right specimens. And I think ovarian carcinomas come with quite a wide variety of specimens. We'll get small biopsies, we'll get the ovary, sometimes you get the ovary and tube. Most frequently you'll get both ovaries and tubes and a hysterectomy. And it's important to note not only what tissue is there, but the extent of disease, the description of disease, and very importantly, the appearance of the surface of the tumor. A full description is necessary, but I think there's some key information that is really crucial to get into the grossing protocols, and that would include the specimen type and the tissue that are present, both what the surgeon told you they sent in and what you're able to identify. The size of the tumor, which is usually going to be the size of the ovaries, as they'll often be overgrown by most epithelial carcinomas. Specimen integrity is important. Was the ovary intact or did it come out in pieces? Some tumors are much more likely to rupture, granulosa cell being a very common tumor that will rupture, and many tumors will be stuck down and cannot be pulled out intact, and that has important points for staging. If the ovary is intact, surface involvement is very important to note. The extent of tumor outside of the ovaries, and then important negatives. Things that tend to be negative are the tubes, the serosal surfaces, and the endometriums, at least grossly. And I find that when there are gaps in the gross description of an ovarian carcinoma case, it's often because the tube is not well described, the serosal surfaces are not well described, and probably most importantly, the surface of the ovary is not well described, and it needs to be very clear whether there was obvious surface involvement or not. If your grossing room is anything like ours, it's a busy place that's staffed by a variety of people, and these days we're seeing increasing delegation of grossing responsibilities to both residents and pathology assistants. And we're very fortunate at our center that we have both the tremendous residents and path assistants who take care of the majority of our grossing for us. But in order to do that, I think it's very important that you have clear expectations of the content of your gross descriptions, but also that they are communicated in a way that it's very easy for you to understand what's there, that it's easy for you to find the information that you need to properly report that specimen. This is a very typical gross description. It's a nephrectomy. It doesn't matter where it's coming from, but I think we all see gross descriptions like this. It's very complete. It's very neat. It has all the information that's in it, but I personally find them very difficult to read, and it often takes some sort of digging around to find out the size of the tumor or the type of specimen that's there, and sometimes that will lead to missing information. Here's the information that's in this specimen. Here's the type of specimens that are highlighted in yellow. They're all there, but they're scattered throughout the description. The main pathologic process in this place is all together and quite neat, but a little bit wordy. And then the secondary findings are scattered throughout. So if you were trying to find out what the lymph node status is, you might have to dig around quite a bit to find it. In order to deal with this and set some expectations for communication in gross formats, I just wanted to spend a couple of minutes talking about a system that we've used at our hospital the last 2 years with I think, really tremendous success in standardizing the format of our gross descriptions. And this is a system that was described out of MD Anderson by Dr. Raymond, And it really comes down to a 5-paragraph system. And these are listed here. Paragraph 1, you include the specimen elements, exactly what was there in the size. Paragraph 2 is the primary pathology. Paragraph 3 is the secondary or adjunct findings. Paragraph 4 is an inking code, and 5 is the section code. And we've adopted this for most of our gross descriptions, including ovary. And I think it's led to clearer expectations of our PAs and residents, and also clearer descriptions. This is what our current protocol for grossing ovarian neoplasms looks like, and all of our grossing protocols look relatively similar. There's preliminary procedures detailed here for how to deal with the specimen when it first arrives, for opening and for inking. And then these are our expectations for how an ovarian neoplasm or cyst should be described. The first paragraph is the size of the specimen, whether the fallopian tube is attached, and all the other organs that may or may not be with it. The second paragraph, most importantly, is the description of the ovary of the tumor, and we have expectations for what we want to see about the external surface, the internal surface, and then describing what the tumor looks like, whether it's cystic or solid. And although these are not exactly templates, they are a way that the PAs and residents can follow through and make sure that they've got the right information attached. Secondary findings, again, the fallopian tube may not be grossly involved, but it's important that it's very accurately described. And then depending on what other tissues are there, we have recommendations there as well. So this is what one of our gross descriptions might look like. The first paragraph describing the ovary and the tube with their dimensions, what the ovarian tumor looks like, what the fallopian tube looks like, how it was inked, and the section codes. So while I don't think it's crucial that every department adapt this type of protocol, I just wanted to put out there as an example of standardization and the importance of having clear expectations for your grossing protocol so that when the slides arrive at your desk, you've got a fair degree of certainty that you understand exactly what the specimen looks like and that it was grossed appropriately. As far as the sectioning of ovarian neoplasms and cysts, it is fairly straightforward, and I think most residents will know that it's generally 1 block per centimeter. But I think that often this needs to be modified slightly depending on the type of specimen. Many ovarian neoplasms are benign, and we will frequently put in strips of a thin-walled cyst, put up to 3 per block, and this will certainly, although adequately sectioning the specimen, will cut down significantly on the number of blocks that are necessary in order to get all those in there. Most tumors, again, are 1 block per centimeter. We're much more interested in the solid or the intercystic excrescences for sampling and would prefer that necrotic areas were avoided. Some of the tumors that we more extensively sample are the mucinous ones, especially if they're less than 15 centimeters. We'll go up to 2 blocks per centimeter to make sure that we've got a good sampling of it. And again, in the sampling, it's important that some of the samples include external surface, either adhesions or surface involvement. If they're not there, then where the tumor closely approximates the surface of the cyst. And I think that follows along with what's recommended in the checklist. These are their guidelines for sectioning, again, 1 per centimeter, multiple strips in 1 cassette if necessary. They have a slightly broader list for extensive sampling, borderline tumors with micropapillary architecture, mucinous tumors, solid teratomas, malignant germ cell tumors. And I think most of us would follow that. Often if you just start with 1 block per centimeter, it's quite acceptable to go back once you've seen the microscopic. Hopefully many of you are familiar with or will have seen a picture like this. This is the CFIM protocol that was developed through the Brigham and Women's Hospital, and the CFIM stands for really seeing more of the epithelial surface of the fimbria. As I mentioned earlier, many studies have recently suggested that the origin of many ovarian serous tumors is actually within the fimbria of the fallopian tube, and that our traditional sectioning, which often focus just on the cornea or on the lumen of the fallopian tube, does not give us enough of the epithelial surface to look at. So the CFIB protocol has gained fairly wide acceptance. What this means is transecting the fallopian tube and taking off the fimbria. The fimbria there are then bisected or trisected, and these go into 1 cassette so that you get quite an extensive look at the epithelium of the fimbria. The remainder of the lumen of the fallopian tube is thinly serial sectioned and submitted in total. It's certainly necessary to use this protocol for any sort of risk-reducing salpingo-oophorectomies, and this will usually be for patients that have BRCA mutation and are having a prophylactic surgery. We use it for all of our ovarian neoplasm cases as well, and often extend it into endometrium because it's just easier to do this up front rather than later on. And it often doesn't take a lot of slides. Those small tubes, you can get an entire tube in 2 or 3 cassettes or 4 cassettes. Sometimes it takes longer, but frequently I find it's much easier to get this done up front than to go back and try and re-embed the fallopian tube if you come across something in your microscopic that warrants it. So I would certainly encourage your centers to adopt the CPIM protocol for prophylactic and consider it for most of your ovarian neoplastic cases. And finally, the staging laparotomy. Most ovarian tumors, especially for carcinoma, will come with multiple peritoneal biopsies and the omentum. And the bottom line for these sort of biopsies is that everything should go through unless you can see tumor. So for peritoneal biopsies, we submit all of the tissue unless gross tumor is present, in which case we'll just put through representatives. The same for lymph nodes. We ask our PAs and residents to try and count them, especially if they're going to be bisecting lymph nodes, even though we know that's not entirely accurate. All the nodal tissue goes through, again, unless there's gross tissue or gross tumor, in which case a representative section is more than adequate. And finally, omentum, if tumor is present, 2 or 3 blocks are sufficient. If there's no tumor present, multiple pieces, 5 to 10 sections. Our protocol here at London Health Sciences Center is 24 sections in 8 cassettes. But I think you need to know that you need to take multiple sections of grossly normal omentum. This is a case we had not too recently, or just recently, where 10 cassettes went through, and this is the 10th section, which shows a little hyperchromatic area, which on higher power does turn out to be a single metastasis from a serous adenocarcinoma. And this is the woman's only site of tumor outside of the ovary, and significantly upstaged her and changed her protocol. So multiple sections of negative omentums are recommended. So let me walk through the checklist that is provided and tell you about some of the areas where it works and where it's a little bit tricky. The checklist can be divided into the procedural descriptions, what kind of tissue you have, the specimen descriptors, the size, the sites, tumor descriptors, histologic grade and type, tumor extent, and I'm going to use the word extent because that includes both metastases and implants from borderline tumors, and then finally the staging of ovarian carcinoma. First is the specimen. To me, this implies what you are able to identify, and this is a select all that apply. So please select all of the tissue that you can identify. Often you will get bilateral ovaries and fallopian tubes in a uterus. The cervix will usually be attached, and there will be an omentum. Peritoneum or peritoneal biopsies, and you may get lymph nodes as well. There is a separate section for lymph nodes, but I think it's best to list them here as well. The procedure section, to me, this is what the surgeon says they have done, whether they've done a bilateral salpingo-oophorectomy, a total hysterectomy, an omentectomy. And it's not uncommon, especially with limited procedures here, that they will tell you that it's a right salpingo-oophorectomy, but you may not be able to initially identify the fallopian tube. And these are areas where there needs to be some very clear communication. It's often necessary to go back to the OR node and determine whether they were able to find the fallopian tube, whether they were able to find both ovaries and tubes, and be very clear that if there's a distinction between what the surgeon told you that they've sent and what you're able to identify. Of course, sometimes the tumor will overgrow the specimen and you're not able to identify the tube just because it's been overgrown and the tissue is not there anymore, and this may need to be clearly put out there as well. As I mentioned, the checklist includes lymph node sampling, whether it was performed or not performed, and the details of this are within the staging area. Specimen integrity, very important in ovarian tumors. Whether the surgeon was able to remove the ovary intact or whether it was already ruptured prior to surgery or ruptured during surgery due to adhesions. It's often not possible for pathologists to determine when the rupture occurred, but it is important to note this. So was the capsule intact, was the capsule ruptured, or was it fragmented? The checklist does suggest that if there's an admixture of benign, borderline, and malignant areas, that it's also important to know which area ruptured, but often this can be quite difficult to do in practice. Primary tumor site. This would seem simple on the face, but often not as easy to do in practice. The checklist asks you to determine whether it's a right ovarian tumor, a left ovarian tumor, bilateral ovarian, or not specified, which I take to mean you can't tell. Often because of the diffuse distribution of pelvic serous carcinoma, it can be really challenging to assign a site of origin. However, the good news is that clinically it may not matter. Extent of disease and the type of disease is what they really need to know to determine post-operative treatment. However, I think it is important in the checklist to pay attention to this and try and give them some indication of where you think the tumor was coming from. So in order to do that, you need some rules or some guidelines to move forward with. Most times, identifying the dominant ovary is not difficult. There'll be one tumor that's larger and obviously has some more extensive disease. So in that case, the contralateral ovary is the one that either has less tumor involvement or appears grossly metastatic or negative for tumor. So appears grossly metastatic, that would be an ovary that has multiple nodules, surface implants, or possibly hilar vascular invasion. So in the case where you have both ovaries and one is dominantly larger and the other one has any of these sort of evidence, it would be prudent to call the primary tumor site the dominant ovary. If, however, there's extensive disease in both ovaries, certainly that's going to be called bilateral ovarian involvement. It's also important to consider surface involvement. If the tumor is predominantly, again, here I'm talking about serous tumors, if the tumor predominantly involves the surface of the ovary and has that sort of shag carpet appearance without a lot of cortical involvement, it's important to consider a peritoneal or fallopian tube source and to carefully look at the other specimens you have and consider where the bulk of disease really sits. This type of question may be more troublesome, and that's when you have a synchronous ovarian and endometrial primary, and that's not uncommon. When you have an ovarian endometrioid adenocarcinoma, probably 30 to 40% of the time there will also be an endometrial carcinoma present in the endometrium. In general, most of those tumors will both be low grade and low stage. And most of the time, it is fairly straightforward to say, these are both grade 1 tumors. They're both confined to the ovary or are showing only minimal myometrial invasion. It doesn't make sense that one is metastasized from one to the other. So in that case, they will be considered synchronous primaries, and you'll need to use two checklists, one for the ovary and one for the endometrium. In making that determination, again, it's the size and distribution of the tumor. If you have an endometrial carcinoma that is a high grade and is extensively invasive through the myometrium with multinodular invasion of the ovaries, it's very likely that those are metastatic from the endometrium. However, as I mentioned, if they're both low stage, it's much more likely they're synchronous primaries. Very helpful to look for the presence of precancerous lesions, either endometrial hyperplasia in the endometrium or endometriosis within the ovary can point to a primary site. And the microscopic appearance of tumor can be helpful. Often there'll be subtle differences in the amount of squamous dysplasia or squamous differentiation between the two that can point you in the right direction. But in the majority of cases when you've got tumors both in the ovary and the endometrium, they are synchronous primaries and two checklists are necessary. As I mentioned earlier, ovarian surface involvement is very important, especially in tumors that do not have evidence of growth beyond the ovary. So when the peritoneal biopsies are negative, it's the surface involvement that determines whether someone is a 1A or 1C and may make the difference between treatment and no treatment. I think the key here is that the surface of ovarian tumors need to be handled very gently. And here at our center, we do not recommend inking the entire surface black. Personally, I think it's a bit rough on the surface of the ovary and tends to do nothing more than use up all of your black ink and get black ink everywhere. So we suggest that there's just selective inking of areas that are identified as being potential surface involvement or the area where the tumor most closely approximates the surface. So with the right grossing and the right inking, you should be able to determine whether the ovarian surface involvement is present or absent. And you should be able to minimize the amount of times that you're uncertain or cannot determine. Of course, if the ovary was ruptured or was received fragmented, they cannot be determined. tumor size does not enter into the grading or staging of the staging of ovarian cancer. However, it certainly should be included in your checklist. All that's really needed, as most ovarian tumors are round, is the greatest dimension, although there is areas here to add in a couple more dimensions. But really the key is what was the greatest dimension of the ovarian mass for both the left and right ovary, depending on whether they're applicable. I believe the cannot be determined comment here would be for fragmented lesions, in which case you may not have the entire ovary, or cases where the tumor is so overgrown that you cannot identify architectural landmarks. I think that most of us are well-versed in typing of carcinomas, and it's important to note that this checklist is designed not only for the epithelial tumors, such as this clear cell carcinoma, but can be used with both sex-cord stromal tumors, such as this granulosa cell tumor, or this dystrophinoma, the germ cell tumors. Like most things in ovarian oncology, 90% of the effort and thought goes towards serous carcinomas, as they are the most commonly identified and dealt with. So I think although the checklist does lead areas for dealing with sex-cord stromal tumors and germ cell tumors, if you're dealing with one of those cases, you're going to probably need extensive comments to describe the tumor fully and to make sure that you've got all of the pieces of information in there. Nonetheless, the checklist does provide quite a long laundry list of histologic types, and these are based on the WHO criteria. The ones that you're going to be using most frequently will be, again, the serous borderline and serous carcinoma types. All of the epithelial types follow this pattern, with the mucinous giving the two types of borderline and a carcinoma, endometrioid borderline and carcinoma, and clear cell borderline and carcinoma. They're all here, though, for your use, although, again, you'll be mainly using it in this area here. I think endometrioid borderline and clear cell borderline tumors are very rare, and even the mucinous carcinoma is uncommon enough to suggest that it would need an extensive comment to fully describe the tumor if you were using this checklist. Other less common types of epithelial tumors are also included in this list using the same terminology. Transitional cell, both the malignant and Brenner type. Squamous carcinoma, which is a pure carcinoma, is very poor, or is very rare. Mixed epithelial borderline and mixed epithelial carcinoma is probably used fairly frequently. In this case, you need to specify the types and percentages of tumor that are present. By convention, there needs to be at least 10% of a second component before you put it into the mixed epithelial carcinoma. And I'm going to be talking about some changing thoughts in histology and type that may make the mixed epithelial carcinoma less common. Undifferentiated carcinoma, undoubtedly many ovarian carcinomas are incredibly ugly, poorly differentiated, and don't lend themselves well to classification, and this can be used here. And the carcinosarcoma, the mixed malignant epithelial and sarcomatous lesion that is not uncommon as well, is included in this list. Finally, in the list are the non-epithelial types, and it's not an extensive list. Granulosa cell tumor probably being the most common that you might use this checklist for. There's areas for other sex-cord stromal tumors. Of course, I think it'd probably be inappropriate to use this checklist for fibrothecoma, but there are other granulous sex-cord stromal tumors that have the potential for spread, and this checklist could be used. The malignant germ cell tumors are rare enough that it's just given a general categorization here, and again, I think you'd need to add a comment just fully describing exactly what sort of germ cell neoplasia is present if you were going to use this checklist. And finally, of course, the other category for things that just don't fit, also needing an extensive comment to describe what you're seeing there. I'm going to talk about histologic grade as well, because I think this is where the checklist can become a bit confusing. And then I want to come back to some new thoughts on merging ovarian cancer type and grade. This is what's in the checklist, and on first reading, it's a little confusing. You have basically three choices. You can use a standard grading system, and most of us would use a three-grade system, well, moderately, or poorly differentiated. Again, most of what I'm saying relates to serous carcinomas. So many of us will use a three-grade system for serous carcinomas, Again, the undifferentiated can be considered grade 4, or it can be classified as an undifferentiated carcinoma. Increasingly, though, there has been a movement towards a two-tier grading system for serous carcinomas and separating them into low and high grade. And I think that there is a tremendous body of evidence that shows that not only is this a more clinically relevant staging system, but it is likely more reproducible for us as pathologists to use. The checklist, again, it becomes a little bit confusing here because it says the two-tier system is really to be used for only serous carcinomas and immature teratomas. But I think the point is once you've made a determination of tumor type, you have your choice of using either the WHO system or the two-tier system. Of course, there's always an other, and importantly, there's a not applicable. And this not applicable is very important because of the wide laundry list of tumors that are available to use with this checklist, and I think most specifically, borderline tumors are not graded, and the most appropriate selection for histologic grade for borderline tumors is not applicable. I think that does run the risk of confusing our clinicians, but I think over time they will come to understand this. Let me talk a little bit about the two-tier system. Again, I'm talking only about serous carcinomas, and this was a study that was published back in 2004 by the group out of MD Anderson. And this is looking at their own experience with using a two-tier grading system for serous carcinomas. The low-grade category have a very mild to moderate nuclear atypia and a low mitotic rate. Most of these are on the borderline side. Often they are what we would consider a micropapillary borderline tumor with invasion. And we'll have a borderline component as well. These are very, very low-grade appearing and actually quite uncommon tumors. Using this system, the majority of serous tumors will fit in with this high-grade category, and I think you would recognize that we're used to diagnosing serous carcinomas because of their marked nuclear atypia and their frequent mitotic figures. So using this system, the majority of tumors that are serous in type will fit into this high-grade category. The low-grade category are often associated with borderline and will frequently have a micropapillary architecture. Looking at their experience, which I think is quite extensive, there was a significant difference in the 5, 10, and 15-year survival between the high-grade and the low-grade using the system, suggesting that there is significant utility in separating tumors in this way. I think one of the best studies that I've seen out there is this one from the Canadian group led by Blake Jokes, and I think many of you will recognize some of the names that were involved in the study. And I think this is a good paper because it brings together so many of the concepts around ovarian cancer grading, but also talks about reproducibility. I think most people would agree that it's very important that in order for a pathologist to get important information, clinically relevant information, it's very important that we do that in a reproducible way. And this group used the two-stage system and a modification of the WHO system, and then circulated the slides and came up with a system that is fairly reproducible. In fact, quite reproducible compared to other ovarian typing systems. This is the modified WHO classification that they have proposed, and I think this is important and has actually gained a fair amount of acceptance. Again, there is the high-grade and the low-grade serous, and we've talked about that. A high-grade serous carcinoma is any tumor that demonstrates any kind of serous differentiation, whether it's solid or glandular or undifferentiated. As long as some of it is serous, they should really be considered high-grade serous carcinomas. Importantly, glandular differentiation is accepted. It does not have to be a papillary architecture. Often in the past, glandular areas have been interpreted as endometrioid, and in their study and with a lot of backup of both immuno and molecular, it shows that most of these tumors really are variants of serous carcinomas. And again, there's frequently marked variation in nuclear size and very frequent mitotic figures. The low-grade serous tumors were often micropapillary and associated with borderline tumors. Clear cell carcinomas have a very distinct papillary and tubulocystic appearance with an eosinophilic stroma in the background. Endometrioid tumors really need to resemble endometrium and will frequently be low-grade and show squamous differentiation. And then the intestinal the mucinous type of tumors are almost entirely intestinal and show goblet cells. And importantly, these are the rare types of mucinous adenocarcinomas that show true stromal invasion in the ovary. So we're not talking about borderline tumors with intraepithelial carcinoma. So using this type of modified WHO classification, they estimate that they can classify about 98% of ovarian epithelial carcinomas within this group, and that the majority of them will be high-grade serous. These are some examples from their paper of what they're talking about, and I think that the high-grade serous is fairly straightforward. Low-grade serous is a somewhat uncommon tumor, but has this very distinctive, rather overgrown borderline appearance that we call micropapillary. Clear cell, again, is a very distinctive appearance with a tubulocystic architecture and a very distinct eosinophilic stroma. It's not just about clearing of the cytoplasm. It's a very distinct appearance. Endometrioid tumors are generally glandular in their differentiation and will show pseudostratification and overlap of the nuclei. And then finally, mucinous adenocarcinoma will often have an intestinal appearance with an invasion. So in looking at this tumor, this paper, I'd recommend that you go to their website. It's still available, and it's kind of neat to look at. There's a training set as well as a test set, and if you'd like to see how your classification compares with this group, you can certainly compare them in real time. It will bring you into about 40 images, and these are all Aperio images that you can move up and down on and make your diagnosis, and then you click on Show Diagnosis, and it gives you what their determination is. And in using this system, this group was looking at kappa values in the 7, 8s, and 9s, which are really impressive for consistency across. And I think their bottom line, and that of many groups now looking at ovarian cancers, is that the majority of the ugly pleomorphic tumors we're looking at are all high-grade serous tumors. And that if you look at them immunohistochemically and with molecular markers, they show similarities across the group, whether they have minor areas with clearing cytoplasm or whether they have some glandular differentiation. It's more important to identify them as high-grade serous. Certainly right now, all ovarian carcinomas with spread outside of the ovary are treated with very similar regimens of cisplatin, but it's very clear that the ones that are most likely to respond to cisplatin are the serous types, and it may be important that we become as accurate as we can be in removing the other types from the mix, the endometrioids and the clear cells, so that we can do better studies on those and determine what the right treatment is. So again, I would recommend taking a look at this paper and this website as a chance to compare ourselves. A couple of other points about grading in the non-serous, and this is where it can be a bit tricky. Borderline tumors are not graded, and the appropriate choice is not applicable. Mucinous tumors, the majority will be borderline, or the malignant ones will be borderline with intraepithelial carcinoma, and generally these are not graded, although there should be some description of the intraepithelial carcinoma. When there is a truly invasive mucinous adenocarcinoma, I think these can be graded using the typical criteria that we would use in the colon or anywhere else. True endometrioid tumors, these are the glandular differentiation. They'll often have squamous differentiation within them as well. These can be graded using the FIGO grading system for endometrium. This is where you look at solid, non-squamous components, and if it's less than 5%, that's grade 1. If it's greater than 50%, it's grade 3, and grade 2 falls in the middle. Clear cell carcinomas are all considered a high grade, and the appropriate selection is not applicable for these tumors. And again, germ cell tumors, really only immature teratomas are graded using a low-grade and high-grade system. The majority of other germ cell tumors will not be graded, and again, you would be choosing not applicable. And finally, granulosa cell tumors grading is certainly controversial, and some of the descriptions of the grading, the mitotic count, should be included in your report. If you choose to grade it, I think you'd have to add that in with a comment discussing the controversies of the grading system. So most importantly, the grading on the chart of the ovarian checklist looks complicated, but in most choices you're choosing either the grade 1, 2, 3 or the low-grade, high-grade, and I would ask you to consider the low-grade, high-grade system for serous tumors. Where you may run into questions are going to be in these areas here in the borderline and clear cell tumors, and the appropriate selection in those areas is not applicable. Checklist contains two areas for describing extent outside of the ovary. And one is for borderline tumors, this area of implants, and the other is called extent of disease outside of the ovary, and that's for true carcinomas and malignancies. The word implants is a term that is associated with borderline tumors to reflect the possible multifocality of serous tumors, and that the prognosis of these tumors, even though they have, quotes, metastasized, is often very good. Again, this will only be used when you're staging serous or seromucinous borderline tumors. The majority of these will be non-invasive implants. And in the non-invasive, it's important to determine whether those are epithelial or desmoplastic. And then the very uncommon invasive implants, which look like a true invasive adenocarcinoma. For example, the majority of borderline implants will be proliferations, atypical proliferations of serous tumors that are sitting very innocently, often in the omentum or in the peritoneum. You can see in this case there are samoma bodies, but there is no reaction in the tumor surrounding it. Desmoplastic non-invasive implants, I think your clinician will describe sort of stripping a plaque off the peritoneum, and you can see that they'll often, although they have a fibrous reaction around them, will be sitting like a plaque on top of the peritoneum or the omentum, and there's no evidence of invasion in between. So it's really a plaque-like implant that are the desmoplastic non-invasive implants. And then finally, the most uncommon type are the invasive type of implants that look like an invasive adenocarcinoma spread from anywhere else, that will have an irregular, destructive, invasive pattern to them. And often the surgeon will find these much harder to resect with having to take some surrounding tissues out around them. So those are the classifications of implants associated with borderline tumors. More commonly for the serous carcinomas and other lesions, you'll be using extent outside of the extent of involvement of other tissues or outside of the ovary to determine the extent of involvement of metastases. Again, you'll be reiterating right or left ovary, right or left fallopian tube, the omentum, the uterus, the peritoneum. Whether you need to define exactly which sites in the peritoneum are positive, you can add that into your report, but it's a plus or minus. The peritoneum's either involved or it's not. And then other organs or tissues. These can be involved or not involved, or if they're not present. And this is probably the most important part of staging, is to determine the peritoneal extent of disease. Optional information, normal findings in the background, and although some of these are optional, I think they'd be very important. Endometriosis is a known precursor lesion for clear cell carcinomas of the ovary, and it's very important to determine whether it's there or not in those cases. Endosalpingiosis is not considered a precursor but can be identified, and you may find other lesions in the peritoneum that you wish to detail in this area. Other optional information, again, these are areas that are growing in importance but are not yet required. Treatment effect, as I mentioned, many patients are getting neoadjuvant chemotherapy prior to their surgery, and if you can give an indication about whether you're seeing a response, and a response would be necrosis, fibrosis of the tumor, that can be helpful as well. Interesting, lymphovascular invasion is optional information, is not part of the staging, and has not been linked to prognostic information, but should be identified whether it's there or not for at least future studies. Ancillary studies, this is where you could put in your immuno findings or any other molecular studies that you're doing related to the tumor. Often immuno is not necessary in the reporting and diagnosis of ovarian carcinomas, but certainly you could put it in here. And if it's available to you and it's in the format of your system, adding in a family history in this side, in this area here could be important, but is optional. So let's finish up by talking about the staging. As I mentioned, the primary staging system that most clinicians are familiar with is the FIGO staging that you can see here. It is aligned with the TNN classification, although you'll notice that it almost all occurs with what's going on with the tumor in the peritoneum. And as I mentioned before, you will see words like implants, metastases within the assessment of the primary tumor, not so much down here in the distant metastases. So let's walk through the staging as it exists right now. Tumor cannot be assessed or no evidence of primary tumor. There will be cases in patients that have had neoadjuvant chemotherapy that there is no tumor remaining, and this classification could be used. Stage 1 is a very important stage, as these are patients that possibly do not need further treatment. And it is possible that patients with 1A tumor confined to one ovary with no surface involvement may not require chemotherapy. So that's a very important distinction to make. In order to make it, you have to have negative biopsies outside the peritoneum, as well as seeing both ovaries and the serosal surfaces. So that's an important clinical cutoff as being the only patients that will not receive chemotherapy in the majority of cases. Beyond that, 1B and on, most of those patients will receive very similar chemotherapy. So in stage 1, it's limited to the ovaries. 1A is one ovary, 1B is two ovaries, and 1C is either the surface or peritoneal washing. So it's going to be in this group here that it needs to be a very clear distinction of the ovarian surface, because it can take a patient from being 1A to 1C and change their treatment options. Stage 2 is extension into the pelvis. And notice I'm using the word extension. This can be used for both borderline and carcinoma cases. So extension includes what we both term implants and peritoneal metastases within the pelvis. So again, it's extension within the pelvis to the uterus, to tumors outside of the uterus, and again with positive washings. Probably the most common stage you'll see will be a stage 3 tumor, and these are where tumors that are spread into the peritoneal cavity outside of the pelvis, and usually involves one or both ovaries. But the stage 3 classifications come down to what the extent of the peritoneal metastases are. Some of this requires some clinical correlation. 3A is a microscopic peritoneal metastasis, such as the omental metastasis that I showed you earlier, whereas the majority of cases there will be macroscopic peritoneal metastases if they're present, and the oncologist will have been able to remove them because they're quite visible. Stage 3C involves regional lymph node metastases. Not only are peritoneal biopsies part of the staging surgery, but it's important to look at regional lymph node metastases, often up to the aortic, and any involvement moves that patient into 3C. The lymph nodes, as I mentioned, are important, although they've already been previously mentioned in 3C. This does give you an opportunity not only to detail the number you examined, but the number that were involved, but it does relate back to the previous staging system. And finally, the metastases. Peritoneal extent are not considered metastases in this staging system. So for something to be a true distant metastasis, there either has to be parenchymal involvement, most commonly of the liver. And this can be a problem because something will come in as a liver biopsy and it's not clear to you whether they pulled it off the capsule or whether it was inside of the liver. Parenchymal liver metastases are stage 4. Anything on the capsule will be stage 3. So often it will require clinical correlation to put that together. Of course, anything in the lungs or beyond is also going to be considered distant metastases in ovarian carcinoma. Not that common to stage a patient here, often because the surgical procedure focuses almost entirely on the peritoneal cavity, and looking for tumor beyond the peritoneal cavity is usually not part of the primary treatment. So as I said, most important distinction is going to be between stage 1 and stage 3 in the majority of cases. And just finally, there are clinical prognostic factors that will relate to the patient's likelihood of responding to chemotherapy and relapsing in the long run. Of course, the most clinically significant factor is the FIGO stage that you in your pathology report will be providing, and this is the key information. But the residual tumor left after surgery also plays a very important role in the patient's response and long-term prognosis. If the surgeon was able to remove the surgery and leave less than a centimeter or less than 2 centimeters of tumor behind, that patient has a much better prognosis. If they were unable to remove the tumor because it was stuck down or because it was encasing vital organs, that patient is much more likely to do very poorly in the long run. And the volume of malignant ascites is also included here, although it really comes down to the FIGO stage and how much they were able to debulk the patient in determining the prognosis of these tumors. So in summary, I hope I've given you an overview of the ovarian cancer staging system, and importantly, the consideration of whether you're going to choose the ovarian checklist or the fallopian tube checklist. I would suspect over the next few years that we're going to see a merging of those checklists with a more push towards identifying the actual site of the tumor, and many of those may actually be coming from the fallopian tube. But for right now, it's playing by the old rules where the bulk of tumor is the checklist you should choose. I've given you some idea of our browsing protocol and hopefully inspired you to think about your own and having a clear set expectations for both the content and the communication if you are delegating your grossing responsibilities in your department. We've covered some of the new thoughts in ovarian cancer type and grading, and I hope you will take a chance to look at the many papers talking about the two-stage high-low grading system for serous carcinoma. There's very good molecular, immunohistochemical, and probably most importantly, our abilities to agree with one another in typing and grading using the system are much improved. We talked about some of the special circumstances in using the ovarian checklist, especially related to borderline tumors and grading, the use of the term of implant or extent of disease, and how the checklist can definitely be used, but you need to be careful in those areas. And then walking through what is really the FIGO staging system for ovarian carcinomas, recognizing that probably the most important distinction we can make in looking at ovarian tumors is separating those that are 1A from those that have more extensive disease outside of the ovary. So I'm going to stop there, and I'd be happy to take any questions.
Thank you very much, Meg. I'm just looking on our screen now, and we don't have a single question, which I guess is a testimony to the incredible clarity and comprehensiveness of your talk. So if anybody has a question, you better get it to me soon, or else we're going to be closing up pretty soon. Okay, here we have one coming in. This is from Raymond out in BC, and the question relates to identification of mucinous carcinomas primary versus secondary in the ovary.
Oh, Raymond, thanks. Yeah, that's a very good question, and I did not touch on it, but that is very important. The majority of mucinous adenocarcinomas that we identify really are metastases from outside the ovary, most likely from the GI tract. And I think a very simple rule is that a bilateral mucinous tumor that measures less than 12 centimeters is almost always going to be a metastases. If you have a unilateral tumor, which is larger than 12 centimeters, more likely to be an ovarian primary. And I think that the classic criteria we use for looking for metastases, the dirty necrosis, the multinodularity, still serve us very well. Immunohistochemically, there is a certain amount of overlap between CK20 in between primary mucinous tumors of the ovary and metastases, so it often isn't a deal breaker, although CDX2 can be very helpful, and WT1 should be positive in some, if not most, ovarian carcinomas. But I think often you can separate them based on the gross characteristics and by looking for the features of dirty necrosis that indicates a metastasis.
Okay, Meg, there's another question from Boyana at the University of Ottawa, and the question is as follows. What is your approach to tumors in the ovary with neuroendocrine differentiation?
If you're talking about the checklist, I think you can, it would of course be fitting under the other category, and you can use the checklist to fill in all of the other areas you need. Areas of neuroendocrine differentiation are often admixed with other tumors and will often be part of an undifferentiated tumor. And when you do some immunostaining, you'll find some neuroendocrine differentiation. I think probably most of those cases are really poorly differentiated epithelial carcinomas. Pure neuroendocrine differentiation is uncommon, although you will see it. And if the tumor does not show epithelial differentiation, is staining positively for neuroendocrine markers, I think they can be used. You can use the standard classifications for neuroendocrine tumors that you'd use outside the ovary. Again, but I think the most important thing is to make sure that this isn't just a minor component of an epithelial tumor, in which case they should probably be treated like a high-grade epithelial tumor.
Okay, Meg, another question from Vivian Frankel, I think in Ottawa. Do you recommend immunostains routinely on ovarian carcinomas? If so, what panel?
Well, Vivian, the answer is I don't use a lot of immuno in ovarian tumors. Generally, I don't think it's necessary for typing most primary tumors. And again, I would refer you to Blake's paper, which I think gives you some very clear histologic clues for typing ovarian tumors. When I do use them, it's usually when we're trying to determine if it's a metastasis. I think we use them occasionally when you're dealing with a primary peritoneal biopsy, and this is going to be the patient's only biopsy. I think a cytokeratin 77 and 20 and a CDX is often very useful. Cytokeratin 720, WT1, and a CDX will often give you what you need. You're looking for cytokeratin 7 and WT1 in most ovarian cancers. I think there's a lot of very specific tumors, but we do use immuno, but for the vast majority of tumors, I'm not a heavy user of our immuno lab, and I don't think most of my partners are either.
Okay, another question from Dr. Zirka. Could you repeat the website with the self-evaluation for typing ovarian carcinomas, please?
I can't repeat the website to you, but let me go back up to the paper, and if you look in the paper, it is there. And maybe what I can have them do is here we go. If you look for this paper at MJF Search Path, July 2010, everything you need to know is there. And good luck on the test bed. It's kind of fun to do.
Okay, another question's just come in. If we have tumor in both ovary and tube with the main bulk in the ovary, however, tube shows component of in situ tumor, do you consider them two separate primaries or use both checklists? This is from Grand River Hospital.
That's a good question. I think that theoretically, most people, if you find an in situ fallopian tube component, would consider that a fallopian tube primary. But as I mentioned at the start, the convention right now is still at the moment, and the checklist makes us very clear that there isn't enough evidence yet to change. The consensus at the moment is to go with the bulk of tumor. I would certainly put a comment in, but in that scenario, I would use the ovarian checklist, and then I would probably put a comment in the end about the presence of a tubular intraepithelial carcinoma. If it's academic interest, it's not going to change their treatment, but I think it'd be very important to track in the long run.
Okay, a question from Dr. Boutros, McMaster Health Science Center. Terminology for PT2/PT3 staging, does it apply to borderline tumors when the word metastatic is used?
Yes, it does. And let me go down a couple of slides here as well, because the terminology that it uses, and see, it says extension or implants. So the staging system is used for borderline tumors. It's talking just about extensive disease. It's not making the distinction between malignant or invasive or borderline tumors. So a borderline tumor with extension onto the uterus would be a P2A or a FIGO2A system, or a FIGO2A tumor.
Okay, here's a question from Dr. Ruth Bayman at UHN. It's a comment. The checklist did not include serous borderline tumors with micropapillary features and serous borderline with microinvasion, and also mucinous borderline tumors with intraepithelial carcinoma or microinvasion. We added these to our checklist and are using at our institution.
I think that's a really good comment, and I think there are gaps in this checklist, and that's one of them. I think that although it does give you a list of tumors that you can choose from, for those types of tumors and many others, you need to add a fairly significant comment describing what you're seeing. I think for the example of a serous borderline tumor with microinvasion, you could use the checklist to call that a borderline tumor because that's how they're going to be treated, but you need to put it in the comment that microinvasion is present for completeness of information. The micropapillary one is tricky, and I think that needs to be in there as well, and I fully agree that those sort of distinctions for centers, especially that are seeing a fair number of ovarian carcinomas, you'd be better off to add those to your checklist.
And if I could just make a comment as well, I think that, the checklists have gone through many iterations over the years, and they're certainly not perfect. I think they're a lot better than they used to be. But, we're in the process through the Canadian Partnership Against Cancer and the Canadian Association of Pathology of setting up national multidisciplinary panels, one of which functions will be to inform the CAP checklist on an ongoing basis. So this is the sort of thing that we could request at a national level to be added to the next iterations of the checklist. This is the sort of thing that we want to have in place over the next several months. So I would encourage people that had comments like this, that we at least then would have a way of actually moving forward and actually getting some representation through the College of American Pathology for these sort of questions.
Yeah.
So I think we're pretty much done now on the question side. So I'll just make a few closing remarks now. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I'd like to thank Dr. McLachlin for a truly comprehensive, clear, and informative presentation today. This is our sixth session in the second series of CAP checklist presentations. We would welcome your comments and suggestions for ways to ensure that these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of the completed online evaluations. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via links posted by Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits. In order to receive your CME credits for attending or viewing the educational sessions, you must complete an evaluation form for each session accessed or viewed in entirety. The link to the web-based survey has been included in the session notices distributed prior to each session. If you are not able to access the web-based evaluation, please contact Sarah Langsher at sarah.langsher, LANKSHEAR, at cancercare.on.ca to request a copy of the evaluation form to be emailed to you. This information was included on the notice distributed prior to this session. Please note, CME certificates for each CAP checklist education session will only be available for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Also, please note that the information for each education session is distributed 10 days prior to the session date and are distributed via the CPAC, the Ontario Association of Pathologists, and the Canadian Association of Pathology distribution list and websites. Please check these sources for the session information. And our next scheduled presentation is on February the 23rd, and I will have the privilege of reviewing the kidney checklist at that time. So thank you very much for your attendance for this National WebEx conference.